Affairs at Emcure Pharmaceuticals. Today, we have gathered here to an August occasion of yet another episode of No Thrombosis workshop series in acute ischemic stroke. With great privilege, I would like to introduce our course director, Dr. Subhash Kaul sir. Sir is a senior consultant stroke specialist at KIMS Secunderabad and chairman KIMS Foundation and Research Center. He has been the faculty for 27 years in Nizam's Institute of Medical Sciences, Hyderabad. Former professor and head Department of Neurology and dean at NIMS. 120 publications in national and international journals. Principal as well as co-investigator of several national and international projects, including largest single center Hyderabad Stroke Registry funded by the ICMR. State Teacher Award by Telangana government in 2017. Past President, AP Neuroscientist Association. Past President, Indian Stroke Association. Past President, Indian Academy of Neurology. Sir, we welcome you for the event. We have our moderator today, Dr. S. Meenakshi Sundaram, sir. Sir is a senior consultant neurologist, Apollo Hospitals, Madurai. Over 20 years of experience in neurology, presented papers at various prestigious national and international forums. Recipient of Best Research Paper Award at the 10th Annual Conference of Indian Academy of Neurology, Lucknow, 2002. Principal investigator for many international trials such as refractory partial epilepsy, stroke, acute stroke intervention trial, and PD trial. Editor of the South Asian edition of the book Practical Neurology by Jose Biller, Waltus Kluwer, December 2020, and also contributed to many books in neurology. Sir, we welcome you for the event. We have our guest moderator today, Dr. Dinesh Kabra, sir. Sir is a consultant neurologist and stroke specialist at SIMS Hospital, Nagpur, India. Presented papers in national and international conferences. Special interest in acute stroke management, secondary stroke prevention. Presented abstract on WhatsApp consult with neurologist can guide physicians to thrombolize acute ischemic stroke patients at World Congress of Neurology, Dubai in October 2019. He has been a member of the many national and international societies. Sir, we welcome you for the event.
Thank you.
We have our first speaker, our case presenter, Dr. Komal Bohra, ma'am. Ma'am is a consultant neurologist at Sri Kara Hospitals, Secunderabad. She has received 4 gold medals in general medicine by NTR University, Vijayawada. Presented paper on spectrum of cardioembolic stroke in tertiary care hospital in South India at INCON 2018. Presented poster on the effect of DBS frequency modulation on fascination in Parkinson's disease patients. Has been a co-author in a case report on longitudinally extensive transverse myelitis due to toxoplasma, an autopsy study published in Annals of IAN, April 2018. Ma'am, we welcome you for the event.
Thank you.
Our second speaker today, our case presenter, would be Dr. Malaya Kumar Mishra, sir. Sir is a consultant emergency and trauma department at Manipal Hospital, Jaipur. After completing his MBBS from Southern Medical University, China, he pursued a 3-year full-time post-graduation training in emergency medicine at AMRI Hospital, Bhubaneswar. He is an American Heart Association certified BLS, ACLS, and PALS instructor and have conducted several provider courses across the city and the country. He is an American College of Surgeons certified ATLS provider. He is also trained as at the Ronald Reagan Institute of Emergency Medicine at the prestigious George Washington University Hospital, Washington, D.C., USA, where he had closely worked with an eminent emergency medicine faculties and participated in a number of didactic simulation lab and emergency ultrasound training sessions. He won many awards in his professional career and participated as a teaching faculty in many national and international conferences. Sir, we welcome you for the event. And with this, now I would like to hand over the session to our course director, Subhash Kaul sir, for his opening remarks. Sir, over to you.
Yeah, thank you, Dr. Sanket. As usual, I would only once again re-emphasize the importance of these meetings, which Emcure company has been doing for many months now. These are basically the experiences of doctors in thrombolizing their patients, the difficulties, the successes, the failures, and then the discussion around it. And as all of us know that such things are not captured in the data, because data is a combination and aggregate of the entire experience. So they will say 70% of the patients benefit, 20% of the patients do not benefit, 10% of the patients get a bleed, but you don't get the actual feel of an individual patient. We learn through data which is aggregate, but patients don't come to us in aggregate. Patients come to us individually, one by one. And the best way to learn from that is by knowing the cases, our own cases and from the cases of others. And that is why experience is important. What distinguishes an experienced doctor from a new doctor? It is because he has seen many more such cases. He has experienced. And Emcure is doing this wonderful forum in which it gives an opportunity to meet the young doctors with the senior doctors, so that this is a good forum in which we can. So you have got doctors from all the seniority, the younger ones, the middle order ones, and the senior. So I think, and I have personally learned a lot from this, from the experience of our younger colleagues. When I did my stroke fellowship in 1996 in US, people in this country at that time did not have much concept about stroke. When I used to say intracranial atherosclerosis, they thought that I was talking some nonsense. They say, what do you mean by intracranial? Or all stroke is intracranial. Why do you even use that term? But today, everybody knows the stroke language. There are such high standard discussions which go on about stroke. And we have an entire new generation of doctors who are very well versed, very energetic in treating stroke. So with that, I will hand over to our moderators. Meenakshi Sundaram is a good friend, and he is a stroke leader of our country as well as in Madurai. He's very good, very humble, very knowledgeable. And particularly, I also welcome today Dinesh Kabra. Dinesh Kabra also is now, I cannot call him young, he's also very senior. And he is very, very stroke aware, stroke ready, and has done a lot of work in stroke. And I am a fan of Dinesh Kabra. So I hand over to both of you, and you can carry on the. And one more thing I want to say before I hand over. It's my pleasure to have Komal today. Komal was my student only, I think, 4 or 5 years ago. And today, on her own right, she is a very important doctor in Hyderabad and very confident, particularly in thrombolysis. I'm very happy. And the other Dr. Malaya, I don't know him, but I'm happy that Dr. Malaya is thrombolizing. I don't know whether you know or not. When TPA came or thrombolysis came, the maximum opposition came from the emergency department. And please go to Google after this finishes. Look into the literature. You have got debates in which the emergency physicians say it's of no use at all. Why are you giving this? So the main critics of thrombolysis have been emergency room physicians. So in that way, I'm very happy that Dr. Malaya, even though he's an emergency physician, he is supporting thrombolysis and, saving lives. So with that, I hand over to Meenakshi and Dinesh. Please take it over from here. After the end of their presentation, then we'll take the question. Please.
Meenakshi, sir, your comments.
So thank you very much for being part of this. And as you said, I'm not your colleague, sir, I'm a follower. Rather, I'm your fan, sir. We are one of the fans of Dr. Kaul, sir. It has been always a pleasure to be with sir, to learn from him. And we are going to have one interactive session without much ado. I request the speakers to take the center stage. Welcome, speakers. Sir, I think we can go straight away to the cases, sir.
Dr. Kabra, any opening comments, or shall we start with the cases, sir?
I think let's start with the cases.
Sir, thank you, sir. Dr. Komal, ma'am, I would request you to initiate the screen sharing so that we can start with the session.
Among all of you. So I'm practicing now at Shrikara Hospital, and we see a lot of stroke cases which requires thrombolysis. And today I'll be presenting one of the case. So this is about 86 years female who has come with, who is a known diabetic and hypertensive. And she had a history of previous ischemic stroke with right hemiparesis, which was 8 years ago. And the deficit has completely recovered after 2 months of the stroke. And coming to the drug history, the patient had history of using aspirin 150 mg apart from her regular anti-diabetic and anti-hypertensive medicines. So she came with the complaints of acute onset right hemiplegia, gaze deviation, aphasia, inability to talk, and decreased level of sensorium. And she has come to our hospital at 4 hours duration of the symptoms. So on examination, the patient was quite stuporous. Her BP was 170 over 100 millimeters of mercury. Her GRBS was 220, and her NIHS score was 28. So this is her NIHS score, where she had very low level of consciousness and dense hemiplegia, and so the score was 28. So immediately we took her for MRI brain with stroke protocol. So this was her MRI diffusion study, which was showing a very big infarct in the MCA territory. So this is a temporal lobe which is involved, the frontoparietal cortex, and the hyparietal. So it was dense MCA infarct, very big infarct. So which is showing ADC reversal, but the flare was not showing significant hyper intensity yet. So there is diffusion flare mismatch which is still present. And this was her MR angio film, which was showing that at the distal ICA and at the beginning of MC, that is M1 segment, there is a cutoff and there is no flow behind. So now we are with a 86 years female who is diabetic and has a history of prior stroke, has come in 4 hours window period, and the scans almost took us 20 minutes. At this films are at 4 hours 20 minutes, and a very high NIHS score 28, and diffusion flare mismatch is present, and the MCA is showing M1 proximal M1 occlusion. So we have because she was in window period, and we have seen for if there are any exclusion criteria. So this was according to the ASA guidelines in the 2019 update, where in the first 3 hours we didn't have any of the contraindication which were mentioned, like no bleed, no trauma, the BP was within the range, no history of surgery in recent past, and glucose levels were quite okay. But the when the window period, she is in the window period of 4.2 hours, and this age 80 years was present, and diabetes with a previous stroke was also present. So this was initially taken as a relative contraindication. So now, though the ESO guideline says that any age can be thrombolized, so then there was a question to thrombolize or not. And the question was mainly because it was a very big infarct, prone to bleed, and a young neurologist seeing it, they had a question, are you sure we want to thrombolize the case? So, here the main points were the favorable factors which were making us take a decision in favor of thrombolysis was patient was still in window period, and there was diffusion flare mismatch. So there is a lot of tissue which was which could be saved, and the worrisome features were age is more than 80, the window period is more than 3, the NIHS score 26, that is a severe, clinically severe stroke, large MCA infarct, and proximal M1 occlusion, that is a large vessel disease. So the chances of thrombolysis, improvement after thrombolysis in large vessel disease is little lower when compared to small vessel disease. So these were the features which were running in our background, should we go ahead or not. So what we when we thought of the guidelines which were ASA 2019 update, it was in the 3 to 4.5 hours duration. They have mentioned that IV altiplase is recommended for those who are less than 80 years, without a history of diabetes and prior stroke, NIHS less than 25, and ischemic stroke less than 1/3 of MCA territory. So our patient was not having any of this. So we were little skeptical, and then if we see about the ESO guidelines, again, it says that age itself is not at all a criteria. So patients who are more than 80 years should be thrombolized, and the strength of recommendation is quite high. Coming to the severe stroke, even ESO has a strong recommendation that in clinically severe stroke, where the NIHS is 25, more than 25 also, we have to go ahead with thrombolysis. Then the blood sugars were quite normal range, and even tenecteplase we can go ahead for large vessel occlusion. So other thing is the recanalization rates, which were significantly usually higher in distal occlusions compared to large and more proximal occlusions. So here the benefit, as the MCA artery was showing occlusion in the proximal segment, the benefit was around 8%. So here we were a little skeptical, though we have given the chance of, we have explained both the risks and benefits of thrombolysis. So we have explained the attendance about the thrombolysis, and because of the high risks, we couldn't thrombolyze the patient because the attendants were not very keen, and patient succumbed after 2 days. So the question which remains in mind is, the ASA has taken all the points together, and it says that it is better not to thrombolize such patients. And ESO guidelines, it has taken the individual parameters into question, and according to that, it is a strong recommendation for thrombolysis. So I would like to have your comments, sir.
Okay, is that the end of the presentation, Kumar?
Yes, sir. Yes,
okay.
sir.
So I think let the moderators begin the discussion. Maybe Meenakshi, Dinesh, you can give your comments. What would you have done?
Yeah, shall I come in, Meenakshi?
Yes, sir.
Yeah. Well, my two concerns are, first, it's a very big stroke. The aspect score is very poor. Hardly 3 scores. See, a decision of thrombolysis is always risk versus benefit.
Right, sir.
This patient stacked with poor prognostic factors.
Yes, sir.
If you look at large stroke, this core volume is at least 100 ml or more. Okay, I have not seen the GRE images. I don't know about the bleed or microbleed, those kind of things.
There was bleed, sir, but the infarct was quite huge.
Yeah, and let me tell you, diffusion flare mismatch.
Yes, sir.
Not equal to penumbra. Okay, so if you have flare negative and if you have diffusion positive large stroke, it does not mean that there is definite penumbra. So here, if I had to thrombolize, I have to have a perfusion study on this patient. Perfusion study not only tells you about the patient who's likely to benefit, but perfusion study also tell you patient who is at higher risk of bleed. There's a paper published in JAMA a couple of years back. It says that if the core volume is more than 85 ml and there is a diffuse perfusion deficit, which is not more than T6, T4 max, then the chance of bleed is very high. Now, my question is that, what is the chance of bleed in this patient? My instinct says that the chance of having a benefit is very low, but the chance, if I get to know by doing a perfusion study, the chance of bleed, I'll be in better position to thrombolize. The fact of the matter is that in our conditions, doing a perfusion study is difficult. We are generally not able to do that.
Yes,
so based on the data that I have, I'm not too keen on thrombolizing this patient.
Yes, sir.
Meenakshi?
Frankly speaking, I would not have thrombolized this patient either, sir, because today we are living in this era when people are with, not only the patients, they are also having brickbats behind us. So when it goes little away from the guideline, which I think the choice should be left to the relatives. If the relatives had agreed, I would have thrombolized. If the relatives did not agree, I would not have thrombolized. And in fact, even by selection criteria for mechanical thrombectomy, now this patient's aspect score would be quite low if you see that. So even for mechanical thrombectomy, it was a difficult case, I would agree, because one of the criteria for 6-hour mechanical thrombectomy is aspect score at least 6 should be there. And when there is less, what it tells us is that maybe that gives an indirect indication that, collaterals are not really working. As Dinesh Kabra sir were saying, maybe if the collaterals are there, maybe by, perfusion imaging, by those things, if you look at the collaterals, if they are okay, then it is fine. Otherwise, it would have been a tough case scenario. Regarding the hemorrhage part,
yes, sir.
There was in 2016 a meta-analysis. We would tend to think that, higher the age, more will be the bleed. But that meta-analysis did not show that criteria. Elderly people more than 80 did not differ in response to IV thrombolysis with respect to the parameter of hemorrhage. That's a surprising thing because we would tend to think that there will be hemorrhage. In this case, the large nature of infarct says that maybe there might be a hemorrhage in this patient. That would have been my worry either. Regarding the point which you mentioned, the 3 to 4.5 hours additional criteria which have been laid down, it is clearly mentioned that they are relative contraindications. Yes, they are not absolute contraindications. And in fact, they were placed in order to satisfy the European Medical Agency for approval purposes. More than anything, that they formed the basis of the ECAS 3 data for selecting cases that was made as a regulatory purposes. More than that, in clinical situations, I would have gone with the patient. I would have told them that, yes, maybe I would thrombolyze, but on my side, go with the patient, and that would be my idea. We'd like to hear from sir. Sir, what would you do, sir? Teach us what we should do in this case, sir.
I basically completely agree with both of you. Actually, to begin with, when the guidelines were framed in 96, the guidelines were very clear. And the main crux there was that do no harm at least. And it was clearly mentioned that you should not thrombolyze big strokes. And by big strokes, they meant more than 1/3 of the MCA. That was also arbitrary only, but at least it ensured that big strokes were not thrombolyzed. The whole discussion starts from the 2019 guidelines, which very clearly said that if a stroke is within 3 hours, whatever is the extent of the ischemia, even if it's a complete MCA infarction, like a malignant MCA, you can still thrombolyze it. And it clearly says it doesn't matter. Even the depth and the duration of ischemia doesn't. It may be just black. Now that looks counterintuitive, but it's all statistical. Based on statistics, they found that when they took all these patients, those which were thrombolyzed compared to those which were not thrombolyzed, their net outcome was still better. So therefore, they came out with these guidelines. And, two of the most important things which used to be speed breakers for us to be over-enthusiastic thrombolysis was removed. One was NIHSS, that if you are within 3 hours, don't worry about NIHS. Even if it is 30, even if it is 42, which is maximum, you can go ahead and thrombolyze, right? And don't worry about the hypodensity. Even if it is dense hypodensity entire, don't worry, as long as you are within 3 hours. Now, I don't understand how that can be, but that is what the guidelines are saying, and I think that is more of a statistical thing. There may be a very small percentage of people who may benefit, but as doctors, we have to understand it is not. That it's very unlikely that this patient is going to recover, but this is what we have to tell the patients, that we have to give him the option. But at the same time, we have to tell him that most likely he will not do well, most likely. Because patients have to be guided, attendants have to be guided. They don't know. It is not just our quoting guidelines and all. We have to tell them what it is likely to be in the real world. Now, Komal, as far as the question comes after 3 hours, 3 to 4.5 hours. What happens in these guidelines these days is that they have class 1, class 2, class 3, quality of evidence, fair, poor, all that. And in that, they practically cover the entire spectrum of possibilities. Now, the one which you showed was a class 1 recommendation not to thrombolyze this particular scenario. But if you read the whole document, I'm quite sure that in one of such boxes, you will say that you may thrombolyze it with uncertain benefits, and that will be class 2B, right? So, which gives you some kind of it allows you to do it without any promise that it's going to be all right. So therefore, if you go by guide, and your European is also telling the same thing, that you can thrombolyze them. And after all, what is European guidelines? Those are 6-7 people who are sitting there and they are giving their personal opinion what they would do. So practically what I have seen, Komal, these days, whenever any patient comes to us up to 4.5 hours, we thrombolyze him. At least we tell the patient that it can be thrombolyzed. And there is really no contraindication other than the brain hemorrhage. All others are relative contraindications. But that does not mean that they will do well. It is our duty to educate the attendants that they will probably not do well. Now, if you would have thrombolyzed this patient, he would have died with hemorrhage, and you would have caused that death.
Yes.
Now here, so that much we have to consider. So that is my comment. I don't thrombolyze indiscriminately. I educate the patient. How does the patient know? He has not read all this stuff. And just because the guidelines are telling us everything, we have our own experience also. No?
Yes.
Once diffusion comes that it is involving your entire, it's a dead tissue, right? For all practical purposes. You are saying something. Yes.
Yes, sir. So actually, we have also told them that there is some in medication called as which can be given because she is in 4.5 window period, but so that can be given, but chances of improvement are very low, and there are more chances of hemorrhage that she may deteriorate.
Yeah.
So after that, we have told them to take a decision after discussion.
But it is important to tell them this thing,
She may
the
not.
option, because these days what happens is, the world has become a very small place. This patient who is being treated by you simultaneously is consulting 10 other people all over the world.
That is the reason, sir. Actually,
including Meenakshi Sundaram and Dinesh Kabra, and you don't even know that. And so after the window period is passed, then one of the doctors or one of the cousins in America would call you that, why didn't you thrombolize him? Don't you know the data? So therefore, it is important that we have to tell them, look, we can give, but in my judgment, it's not going to help you. So fine. But we have to guide the patient.
Yes.
You were saying something.
Actually, she was IAS officer's mother. So they were like, we know many doctors, even we can ask them. I was very clear that this is the option, and there are more chances of hemorrhage. And one thing comes is they see a young doctor and they are little more confused to take a decision. So in that's why I brought up this case, that because we were on the background, we were praying that they don't opt for thrombolysis. So yes.
Yeah, that's good. That's good. Dinesh, I was very interested in your comment about the perfusion studies. I think perfusion studies would be very helpful, particularly if we have to extend the, not only in this case, but in the genuine cases who might benefit, particularly if we have to extend thrombolysis, IV thrombolysis window to 9 hours. Because in 9 hours, your diffusion-perfusion mismatch will not work because flare will be there. Diffusion-flare mismatch will not work because flare will be there, but it is the perfusion. But Dinesh, the at least in Hyderabad, the problem is that the perfusion studies are not being done, and they are not being done with the rapidity and with the expediency as we expect in a stroke. Perfusion studies are being done for brain tumors, where you can wait and all to see the vascularity of the brain and all, but they have not become popular in acute stroke in Hyderabad at least. And I work in a center which is very advanced center in neuroimaging and all, but perfusion study is still not a favorite. What is the experience in your center? Are you doing it routinely?
No, we are doing it very rarely. It's not.
So what is the reason? Meenakshi, is it being done routinely in your perfusion study? We talk about it, but why don't we do it? What do you think?
Sir, we do it, sir. Actually, we look for diffusion because our radiologist is there.
Not diffusion. We are talking about perfusion.
Yes, sir. Perfusion only, sir. He is there. Whenever we have a trouble, we do a perfusion studies. Now we have got ASL also. So we are, better off in that way. We are able to do it. But
ASL, we are doing it routinely, but we don't do a post-contrast perfusion studies routinely.
Yeah, I mean post-contrast perfusion.
Yeah,
which is the one which is recommended.
Yeah.
Our radiologist likes it and he does it, sir.
No, Meenakshi.
Yes,
it is not. No, that's true. I'm telling you of a scenario that a patient at 1:30 a.m. in the morning comes with an 8-hour history of stroke. It is dead night, midnight. Now he has crossed the window period. Will the perfusion study be done routinely in your center?
Yes, sir. Yes, sir.
No, that should be our aim. We are not doing it as yet. Yeah, that should be our aim because we can take many more patients then.
We are not doing it either.
Yeah. Good.
Because our intervention radiologist is a very enthusiastic person.
Does it take a lot of time to do? How much extra time it takes?
10 to 15 minutes it takes, sir.
Okay.
Yeah, one thing about
inject the contrast and then sit and read. They do that mapping and show to us.
So is it possible? No. Is it possible? See, one of the things when I went into this perfusion, what they told me that it is difficult for a technician in the middle of the night to do it and all that thing.
Yes, sir. Yes, sir. The radiologist has to be there, sir. The interventional radiology guy has to be there, sir. Because interpretation we will not be able to do at all. They do that there and they sit and calculate the MTT and many stuff they do it there. We require them there, sir.
So this rapid software, does it automatically calculate that or no?
we do not know how to do it, so they have to come and do it. That is the reason. It is my inadequacy, I must say.
So this is the problem. This lack of perfusion study, which in spite of so much of advancement, we are not able to bring this into our routine armamentarium.
Dr. Kumar, very good point here. See, we have a Siemens CT and we have a Siemens MRI. They have a different protocol of doing perfusion studies. And the perfusion studies, different studies give you different results. So we have to use the perfusion study which is validated. The validated studies will calculate core infarct according to the cerebral blood flow study. A few years earlier, the core infarct was calculated according to cerebral blood volume. This cerebral blood volume will overestimate the core infarct. So not only we have to do a perfusion study, but we have to do a perfusion study according to the accepted criteria, not according to the random criteria. Different machines have different criteria. So you cannot apply that criteria to your patient, because now CBF is used for the core infarct and Tmax 6, more than that, is used for calculating the penumbra. So only with a T6 max more than that is it's a perfusion deficit, and tissue which is having less blood supply, less than 30% to the contralateral side, is a core infarct. On a CT scan, on a diffusion, of course, you will see a diffusion volume which software can calculate and tell you this is the core infarct. So different machines are using different software. They are using different things. So that actually makes things very difficult.
So Dinesh, this CT perfusion and MRI perfusion technology and criteria would be almost same, or they are different?
No, they are not same. See, these days we calculate core infarct according to the cerebral blood flow. In 10 years back, see, I just to be anecdotal, I got educated for stroke in London, Ontario, and my colleague Tingley, he invented perfusion studies, and he sold his stuff to GE machine. At that time, they were calculating core infarct according to cerebral blood volume, not flow. And there's a different result if you calculate by different method. So I think we have to do it. We have to do it properly. Then only there is pleasure in doing it. And see, in my center, we don't do it routinely. So I'm not very confident of doing it. But I've seen a lot done in my fellowship time. And it is not difficult at all.
And I'm not still sure what should be the mismatch, 1.2 or 1.8.
Sir, only diffuse 3 trial use that 1.8 criteria.
Yeah.
Rest of the trial, mostly they use 1.2.
Yeah, that's right. Somewhere I'm reading 1.2, somewhere I'm reading 1.8.
Only one diffuse 3 trial. See, in trials, sometimes they have to have a very liberal criteria so that the trial succeeds. They don't
because if it is 1.2, more patients can be included.
Yeah, but they want to try to succeed, so they are very selective. They want to take very good patients so that things go well.
But I think that so therefore what I learned from you is that the next frontier for us, those who treat stroke, to be accomplished is to convince our radiologists to do this perfusion study and validate it.
Absolutely, and do according to the criteria that are globally accepted.
Yes. I think rapid software is widely accepted, but everybody doesn't have rapid software.
That is very costly. Not every center can afford it.
Yeah, please, sir, make your comments.
The point is, ignorance is bliss. So I did not know so many things. We just do it. That is all. Our radiologist comes and does. So I did not have any knowledge of what Dr. Kabra sir just shared with us. Thank you, sir. So I'll ask my radiologist what he is actually doing.
And in our next meeting, please tell us so that we can push our radiologists then.
Yes, he routinely does. Whenever this problem comes, he immediately comes, he takes over and he does that for us. The second point is, after saying all these things, he recently shared an article which said that after everything, perfusion studies are not helpful in this situation.
Who said that?
He showed us an article. I will share that article.
I think
after everything, this is what I said. You are doing everything and then sharing this with us. There's a doctor and saying he told.
No, my radiologist also tells you the same. I tried to connect, and my radiologist is very accomplished. I told him that you should do it. He said, Dr. Cole, this is all hogwash. These perfusion studies are of no use. So that's why. But in the literature, we don't find like that.
These are useful when you do extended time window interventions. Sometimes these are useful. When I was doing fellowship 20 years back, 16 years back, we were paid $200 for he wanted to validate his software. So we were paid $200 for taking one patient with perfusion study. And my entire 2-year fellowship, I took only one patient because we could take a decision without perfusion study. Why would you do a perfusion study? Perfusion study is rarely required within time window, but an extended time window. See,
after this 9-hour window, I think it has become.
I agree with you. In extended time window, either use a Dawn criteria, which is clinical radiological mismatch, or you use a perfusion study criteria.
No, perfusion for IV, you can't use Dawn. Dawn is only for mechanical.
Yeah, mechanical thrombectomy.
But, this perfusion up to 9 hours is for IV thrombolysis.
That makes... 4.5 hours to 9 hours. IV thrombolysis is still not well established, you see.
No, but the trial is there, no?
But it's still not well established. Some European guidelines say you might do it. And American Stroke Association guidelines says you may not do it. So 4.5 hours to 9 hours still a gray zone for me.
But to take that decision in that uncertain window, you need a perfusion because they did CT perfusion.
Yeah. But the newer papers also coming up. In JAMA, there's a paper where they are thrombolizing based on plain CT scan. You will see these results subsequently. The plain CT scan has got very good aspect score. People are saying that you can get good results, which are comparable to perfusion studies.
What has happened is that after we have got so much used to MRIs that we have forgotten how to look at a CT scan. We fail to detect. We are so much used to the clear images of MRI that we easily miss subtle signs in CT. We have to retrain ourselves in CT scan.
Sir, in NEJM, there was a recent review article last year, which did talk about the 9 hours window and has given like a guidelines in that. The second thing is that doing CT scan with the angiogram. So when we go for training our people outside, we tell them that if you want to do it in an extra window and you have no MRI software, you could do a CT brain even without a perfusion software. You do a CT cerebral angiogram. Look at the source images of the cerebral angiogram and you can make a surrogate marker where you find the core by looking at the stroke window made in your CT scan. Subsequently, use the angiographic studies, look at the core. Around that, there should be no vessel. The vessel should not reach the core. If that is there, then we say it is a perfusion, this one. And we encourage them to do it, sir. One doctor has recently done that. I'm aware of that. But more often than not, it is a training, I think, sir.
Dr. Sundaram, do you do 4.5 hours to 9 hours IV thrombolysis?
Sir, because we have mechanical, we straight away go on with that. But for patients who cannot transfer, we tell them, sir. As one man, you have put that WhatsApp thrombolysis in a similar manner. When they cannot transfer in that 2-3 hours, we tell them that you try to do a CT. Only thing requirement is that your CT angio machine should be at least 16 slices. Because there are places which have 4 slices which don't give a good data to us. Minimum 16 slices or 64 slices is good enough. 16 slices minimum. We do an angiogram, show us the source image to us. We will see whether it is there. If it is there, you can go ahead. If the patient is willing, you are willing. You transfer to us, that is the best for me.
Just a point. IV thrombolysis without perfusion studies, an extended time window is risky.
Agreed, sir. Completely agree.
So I think we had a good discussion. We can thank Dr. Komal for a case.
Thank you, madam. It was a great case and tough case, really, sir. And the thing is that with thrombolysis, she would have died, and without thrombolysis, she has died. So maybe we could have thrombolized and seen, given the benefit to her. That is wisdom in retrospect, I think, sir. We could have aggressively done that.
Yes.
So thank you, Komal.
Thank you so much, sir. Yes.
Thanks,
so next, Meenakshi, you can invite the next speaker.
Sir, can we ask the second speaker to present this one, please?
Yeah,
after that very heated discussion. Welcome, sir.
Yeah, very good evening to all. I think it's a very elaborative discussions we had. And I'll be sharing my slides here for the next. I think my slides are visible. Yeah, to start with, there is a 42-year-old female. She's a known case of diabetes mellitus on OSA since last 3 years. And suddenly she presented to us with sudden onset of retrocerebral chest pain, like for 1 day history. ECG was like normal sinus rhythm with a heart rate of around 60 minutes per minute. And there were T-wave inversions in the lead 2, 3 and AVF, and in the lateral leads like V4 to V6. Echo was normal and the ejection fraction of around 60%. So we put a tagline of diagnosis as ACS or unstable angina. Then like subsequently we involved our cardiologist. Okay, and the coronary angiography subsequently done and suggestive of single vessel disease of left circumflex artery. So there was 80 to 90% of stenosis. Traditional, like then she was proceeded for percutaneous coronary intervention to L6 with drug-eluting stent successfully. Now, after that course of procedures, she developed immediately like complaining of headache, giddiness, diplopia, and vomiting. So we did a CT scan initially to rule out any kind of bleeding manifestation is there or not. So like this was my residency program days in JIPMER. So like after that we involved our neurology, and during the examinations it was like there was right eye cranial nerve 3 palsy was there, and rest of the motor and sensory systems are normal. So we probably thought of it could be because of posterior circulation stroke. So an advice for MRI and MR angio intracranial. Initially the MRI brain suggests like no evidence of infarct or any hemorrhage. And subsequently the diffusion weighted imaging suggested of multiple embolic infarct in the midbrain, and it could because of possible posterior circulation stroke. Then we moved into cerebral angiography, and all 4 major vessels are normal. No evidence of any thrombus or embolus or plaque formations were there. So subsequently we put a diagnosis of acute coronary stroke like syndrome with PCI interventions. It could be because of posterior circulation stroke. So repeat neurological referral taken, and they have advised continuation of dual antiplatelet therapies. Like we did a like retrospective studies in our hospitals, like for the patients undergoing cardiac interventions for coronary disease have a very procedural risk for stroke, and stroke during and after the diagnostic cardiac catheterizations varies from 0.11% to 0.4%. Incidence of cerebral hemorrhage, especially for after the percutaneous coronary intervention, it is up to around 0.3%. In hospital mortality, it ranges from 25 to 44%. And we did several studies completing of around 300 patients altogether, and we came to a conclusion that rapid recognition of a stroke and immediate intervention improves the outcomes, and identifying the patients at risk, understanding symptoms and treatment is vital. So we have alarmed our cath lab team must be aware because of hospital protocol, like should anyone going for PCI intervention should suffer a stroke during and after the procedure. Like there are certain risk factors involved after PCI interventions, like suppose if somebody is having AF, atrial fibrillation in ECGs, or some recent valvular changes undergone any valvular surgeries. So these are the patients that are prone to develop cardioembolic kind of strokes. Stroke symptoms, like basically in general populations, around 80 to 90% of embolic stroke affects particularly to the AC circulations. And for cardiac catheterization populations, more than 50%, as I mentioned, they suffered from cardioembolic stroke that resulting into vertebrovascular circulations. So 20% of the cerebral blood flow traverse the posterior circulations, and even small emboli in the can cause significant neurodeficits. And symptoms, basically, they will be presenting to us with like facial paresthesis, dysphagia, sometimes dysarthria and hoarseness, with motor weakness and diplopia. Like there are certain neurological deficits noted in general during the stroke in cath lab are basically with the motor weakness, aphasia, change in mental status. Basically, it is very mimic kind of pictures. Patient might be under sedation, or it's very difficult to identify the stroke. But definitely, there is a stroke mimics when somebody is presented to us with seizures, hypoglycemia, and migraine. We are very difficult to diagnose initially. And coming to the recognition part, recognition of the source and type of infarct by determining which type of immediate interventions will be the most beneficial for the patient, as we discussed recently in formulating overall acute care treatment and secondary stroke prevention plans. So once the symptoms evident, the stroke team's respondents should be notified, and there is an assessment includes vital signs, including basic neurological examinations, and we should do for every 15 minutes. And definitely we should not forget by examining the NIHS part. The symptoms must be confirmed as a result of stroke rather than the possible neurological events such as seizure or sometimes hypoglycemic or brain tumors. Yes, like in our centers, we basically we have certain protocols to follow. Anybody presented to us in window period, we first do CT scan, and subsequently, if there is no bleed or there is nothing, though no abscess formations, no more than 1/3% of MCA is involved, then definitely we move into the MRI and subsequently MR angio in a routinely practice. And I will be concluding with this. Stroke has an uncommon but devastating complications of cardiac catheterizations. Pre-procedures identification of the stroke yields a very high risk for the patients. Having patients well hydrated prior to the procedures, using catheter techniques to minimize the trauma, and judicious use of ventriculography is very useful. Initiating immediate patient assessment by doing NIHS score and intervention in every stroke patient is very useful. And I would like the moderator, sirs, to give comment on this. Thank you.
Meenakshi, please carry on.
Thank you, sir. It's a very interesting case, really, because stroke and myocardial infarction being manifestations of the same disease in two different places. So, but many times they do not co-occur, fortunately for us. But here is a patient who has got this. And probably after cardiac catheterization, the mechanisms which we think of would be that the atheroma get dislodged, or the calcified plaque get dislodged, or the metal piece could have dislodged. These are things which are thought of. In fact, there have been many, data from about this as well in the form of initially only case reports. But when you look at only the case report, there may be a bias because patients who were thrombolized and they did not do well will not be published. Patients who were thrombolized after that would be published. And that is the reason why there'd be a bias. But later on, large data have shown that even these patients can be given the benefit of thrombolysis, keeping in with the same guidelines you would have evolved, if not for the MI. But the additional points we need to, that is 3-hour window, 4.5-hour window, mechanical thrombectomy window, everything remains the same in patients who have got, stroke following a catheterization as has been done in this patient. The additional points will be that these patients would have received heparin. So if you have to thrombolize them, then we'll be sure that heparin is not creating a trouble for us. We have to check the APTT. The APTT should be permissive for us to thrombolize them. There are papers which talked about reversing the heparin with protamine and then thrombolizing, but I do not know whether it is of really any great benefit. The second thing which we would be considering as a high risk would be that many of these patients would be put on GP2B3A inhibitors, abciximab and things like that. Whether we can really thrombolize them at the time will be a difficult thing. But people, preliminary data has said that probably it is safe and it's left to the discretion of the doctor as well as what will the patient accept for us to go ahead and thrombolize. The third thing will be that the patient would have been given loading dose of aspirin, clopidogrel, so many things would have been given. So the risk of so the risk of hemorrhage should be thought of when you are going to thrombolyze them. But after all these circumstances, as of now, the recommendations say that you could very well thrombolize them. You can subject them to mechanical thrombectomy, explaining the risk of bleed and all those things in this given patient. Surprisingly, for unknown reasons, I don't know whether reasons we will ask Call sir and Kabra sir whether they can tell us. Incidence of stroke is more common in the posterior circulation following cardiac catheterization procedures. I do not know why. More than that, generally strokes will be more common in anterior, but this setting is a fresh thing for posterior rather than anterior. I do not know whether there is indication for that. I will share only one experience as anecdotal after I hear the comments of Sir and Dr. Kabras.
Dr. Cabra.
Share at the end, I will share.
Dr. Cabra.
I sort of echo the thoughts of Dr. Meenakshi. He has told everything that needed to be told. Few things that I would like to add. You need to know the dose of heparin that was given. If it was given, normally cardiologists would give around 5,000 units of heparin. That's okay. Somebody is given heparin and DVD prophylaxis dose, you can go ahead with IV thrombolysis. Somebody is given more than that, then that's an issue. Then the risk of IV thrombolysis induced bleed will go high. The young 42-year-old man has a stroke, peri-procedural. If everything was okay for IV thrombolysis, I think I would have gone. Am I audible?
Yes.
Yes.
Yeah. So as Dr. Meenakshi says that, if everything is okay, we could thrombolyze these patients. If time window is okay, if heparin is not given in therapeutic dose, of course, aspirin and clopidogrel would be given in high dose. We would take that risk because the risk-benefit ratio is generally in favor of patient getting thrombolysis. So that's the way I would look at it.
What was the deficit of this patient by the time you called the cardiologist to see him? Or by the time you saw him, what was the deficit of the patient, neurological deficit?
Sir, basically, there was limb weakness and there was completely aphasic. The patient presented to us and there is history of diabetes in last 3 years and presented to us with retrostomal chest pain. While doing the procedural things, she developed headache, diplopia, and vomiting.
No, when you saw the patient at that time, she had a hemiplegia?
No, sir. There's complaining only giddiness and headache.
That is all.
Yes.
Only giddiness. Only
giddiness, vomiting, and headache.
Yeah, and there was no focal neurological deficit.
No, sir.
Because
he talked about third no palsy. He also said dysarthria and third no palsy is what he presented, sir. Fortunately, the MRI did not show a large infarction.
There's only cardioembolic kind of picture, sir.
Unsteadiness was there?
Was there unsteadiness?
And yes, sir. There was giddiness.
Was he able to walk?
Not able to walk, sir. There was gait ataxia, sir. There was gait ataxia.
So there was gait ataxia. There was dysarthria. So there was disabling deficits.
So after this, was the MR angio done? After this event happened, was the CT angio or MR angio done?
Sir, MR angio done, and there was evidence of all 4 vessels were normal. No evidence of any thrombus or embolus present.
Now you see, basically, I completely agree with Meenakshi and Dinesh that as a general rule, post these cardiac procedures, you have to treat them same as any other stroke. So if you get a call from the cath lab, it is not rocket science. You have to just know, is it a stroke? Does he still have deficits? And if he has deficits, then I'll thrombolyze him. Now, of course, you have to check APTT because of the use of heparin. And if APTT is high, then try to see if there's any vascular occlusion. Because if there's vascular occlusion, you can do mechanical thrombectomy even if APTT is high. APTT high is not a contraindication for mechanical thrombectomy. It's a contraindication for IV thrombolysis. But if you have APTT high, means more than 40, and there is no vascular block, then obviously you cannot do anything. So what was his APTT in this patient after the event happened?
Sir, his APTT was in higher side.
So maybe that was the reason why you didn't do IV thrombolysis. Was it more than 40?
Yes, it was around more than 40, sir.
So it would have been risky to thrombolyze her. But suppose if it was less than 40, probably one could have thrombolized.
Okay.
You know, this decision looks very easy today because it's all in guidelines. But 10 years ago, it used to be a major debate. Should we thrombolyze or not? What will happen and all? But today it has come clearly in guidelines that you can go ahead and thrombolyze, but only be careful about the APTT. That's all. So basically, I completely resonate with
Dinesh and Meenakshi. I don't have anything extra to say.
Yes, sir.
But I remember since we were talking of perfusion, some years ago, Meenakshi, this is also a response to your comment. I had a similar patient. As you get older, you accumulate stories and stories and stories, and for everything you have a story. So whenever I hear any comment, I'm reminded of a story. Besides, that's why elderly people become boring also sometimes, because they repeat the same stories. But once you are telling me this, I remember about 10 years back, I had a post-cardiac cath stroke just like this. And he also had in posterior circulation. Meenakshi, you may be right, but I never looked at it that way. But my patient also was in posterior circulation. And I did not know, should I thrombolize him or not? Then what I did is that I did his perfusion study. I made the radiologist, because it was in broad daylight. It was daytime, 12 o'clock. I caught hold of my radiologist. I said, no, you have to do perfusion study in him, because if there is a mismatch, I'm going to thrombolize him. That time the guidelines were not so clear, right, as they are now. So we did a perfusion study, and it was shown there is no diffusion-perfusion mismatch. So I thought then I will not gain anything from this patient. I often show that case in my presentation when not to thrombolize. So there was no diffusion-perfusion mismatch, so I did not thrombolize. The patient recovered very well afterwards. But today I will not ask for perfusion study. I'll probably go and thrombolize him if his APTT is normal. But Meenakshi, we are waiting for your anecdote, which you have kept in suspense so far. We are waiting for that. Tell us.
I had actually told that anecdote last time. Before that, sir, this patient we have had this experience, sir. We did not have the fortune of examining them in detail, because neither the ICU consultant, because having a myocardial infarction, cath, and then making them walk would be very difficult for us. So we have not done that. I should admit that if I had asked NHS this patient, I would not have been able to give, because our examinations most of the times at this point of time has been cursory to the level whether I can thrombolize or not thrombolize. Beyond that, I have not examined detail. I am happy you have picked up the third no palsy and then dysarthria and gait ataxia. These are difficult things in our setup, at least I can say. Our ICU team would not allow us to touch these people. That is one thing we face. Regarding the anecdote, one of my cardiologists, I think I have told you once before, is a brilliant cardiologist, works in another hospital. We were the only people doing thrombolic. This happened in 2006 or 7, I do not know. Only altiplase was available. And he had a mitral valve disease, and he was actually doing a cath procedure on that patient. On table, he developed stroke. She developed the patient, she developed stroke, and he called me and told me about this on the phone. So at the time, I said that we had to give, IV thrombolysis, we had to give thrombolysis. And at the time, we were 2008 or 9, so we were contemplating on the intra-arterial part and all. So I told him we had to give, IV thrombolysis or any of those procedures, you have to give only altiplase we need to give. At that point of time, in their hospital, they did not even have altiplase. So only our hospital had, and the time for us to, get it across to that hospital will be at least 45 minutes. He said, what will I do in the cath lab? Can we use streptokinase? I said, no. Australian streptokinase trial, even for IV thrombolysis, has been risky and don't give. And he cut down the phone, and then after that, fortunately, he did not listen to me. He gave IV streptokinase, intra-arterial streptokinase, because he was in the cath lab. He took it there, gave it. He said the vessel was blocked. I'm opening it. He gave it, and the patient did extremely well. No deficits when he walked out of the cath lab. The point is no CT scan. I said, why didn't you publish it? He said, where is the proof for me to publish this? The patient had stroke. I only saw that, and my staff has seen that. Even the relatives would not believe it. There is no scan done for this patient for me to show. And their hospital did not have MRI at the time in-house. So what am I going to do? But I've seen this happening at that time. So this answers your question, cardiac catheterization and thrombolysis. We can do it. Fortunately, I think that there are two reasons which benefited that patient, because the stroke thrombolysis was done almost immediately. The time window was very, very, very short. Witnessed the stroke and did it. Even before we realized whether it was TIA or not, he had done that. Second thing is that he was right on the artery for him to go and lyse it. And whatever, medication was given was working at the time. This was my interpretation of that case, sir. That was intra-arterial, in catheter, in the lab, streptokinase, market benefit to that patient. No deficits.
No, I can find that story very convincing. Because you see these Australian streptokinase studies and all, I think they were intravenous streptokinase.
Yes.
And they had used very huge doses, myocardial infarction doses. So they got severe bleeds. That's why it was shelved. And then drug companies were not interested in doing these studies because streptokinase is a cheap drug. They would not make any money out of it. Otherwise, streptokinase is a good drug. For cardiology, almost half a century it has saved people from myocardial infarction. We cannot underestimate. I'm sure it works in stroke. And probably in your friend's case, he has gone intra-arterially. The dose used must be small.
One-third dose.
Yeah. So I'm very sure that he must have done well and he has done the right thing. But of course, his case report probably, there are some journals which would accept it. Many journals will not accept it. But it's a good learning from us. There was before this TPA came, there was a PROACT study. And PROACT study used urokinase. And they had good results. PROACT 1 was very good. Then they did PROACT 2 also. But by the time alteplase came and it overshadowed everybody else. But otherwise, these urokinase, streptokinase, they are nice drugs. I mean, they also lyse the clot. Why not? Yeah?
Shall I tell a story in 2 minutes?
Please, we want to hear only stories. That's right.
In 1958, first successful data of thrombolysis published in JAMA. After that, there was a lot of thrombolysis done in pre-CT era, where the results were bad and it was abundant. And there's a very good article by Werner Hacke. He writes about his experience in thrombolysis, my good times and bad times. Werner Hacke writes that, I did 3 years of psychiatry. And then he started a residency program in neurology. And after 2 years of working in neurology, he was put in a ICU, 6-bedded ICU. He said, we used to see a lot of patients who had brainstem stroke and used to die and have a very bad outcome. He said, once, a young lady came who was doing exercise in the gym and she came comatose. And he says, my professor was Professor Ploik, who was a psychiatrist, and Zoomer was a neurologist and you used to do an intervention also. So, I just asked Professor Ploik, can we put a little bit of streptokinase in the artery and see what happens? Ploik agreed. And Zoomer, who was a neurologist, he was learning intervention. And he said that Zoomer put a catheter in the vertebral artery and put 320,000 units of streptokinase. And he said, the lady woke up next day and she walked away in 2 days. And this was the re-beginning of IV thrombolysis. He published that case. Subsequently, he has a series that was published. And then, then the further trials started and the NINDS, and ICAS, Werner Hacke did ICAS 1 and ICAS 2. And so this streptokinase thrombolysis using a catheter in a lady was the beginning of a new era of thrombolysis. It's a wonderful article that everybody should read in cerebrovascular disease, my good times and my old times, my bad times. Must read. Everybody must read it.
Yeah. I think I have probably in that stroke forum, probably either you or somebody once posted a similar article where they have showed that first IV thrombolysis was done in 1958.
Yeah, it was done using IV thrombolysin.
Yeah.
They used to diagnose stroke clinically and by doing an angiogram. They did an angiogram, they saw a clot. So they thought that now it is ischemic stroke. Now it's thrombolysis.
So I like that because I was also born in 1958. So I was born in the year of stroke thrombolysis was born. I will use it in my next talk. That's very nice.
Yeah.
Plasmin was used and the paper was a failure because they used up to 72 hours they used to give this. And that was one of the reasons why they saw hemorrhage. Autopsy proven hemorrhages said that it was not useful. After that, plasmin came. And then we went to streptokinase. Actually, we were leading the race before the cardiologists. Unfortunately, somewhere, we lost the race and they went ahead and went for all those data, Gusto data, GCP, all those things. They came and they took over us and they gobbled us up.
Yeah, but that is the general trend. We are always 10 years behind them, which is not a bad thing. We are thinkers. We think also. The cardiologists don't think. If you see right from beginning, from the days of aspirin, they used aspirin before us. After 10 years, we followed them. They used thrombolysis before us. After 10, 15 years, we followed them. They did interventions before us, and now we are doing interventions. The last to join the bandwagon is ticagrelor. Now, everybody is using ticagrelor in cardiology, and we have started using it now. It has come into us, So that is okay, because after all, blood vessels are same. So I wouldn't say they are beating us. It is just because, heart is not as delicate as brain. We have to think before we. Brain hemorrhage, there is nothing like hemorrhages into myocardium, but brain hemorrhage is a real risk.
Heart is forgiving.
Yeah, it's forgiving. One thing, Komal, I would like to ask you. No, actually, I'm taking your case, but I would like to know from our panelists also. Your patient had altered sensorium, right?
Yes, sir.
So how do we? This question I have asked Werner Hacke also. This doubt has remained with me for the last 30 years, and I keep on asking everybody the same question. It's a very simple third-year student's question. That when a patient is altered sensorium, how do we calculate his NIHSS? Because if you go by the NIHS scale, if a person has altered sensorium, he gets a score of 3, right? So then his score will remain only 3. But actually, he may be having much more deficits than that. So how do you do that in your practice? Somebody told me, I discussed with many people, they said, no, you give him 3 points for that, then all the other things which you are not able to measure, give the worst score and calculate. By default, give the worst score. And then you come to a score. But I have not read about it anywhere that how do you calculate NIHS score in a patient who is drowsy and uncooperative for a neurological examination, unable to do the neurological examination. Dinesh, you have any comment on that?
See, NIHS pamphlet says, try to use your best judgment. So if you are not able to give the worst score.
Okay, that's right. That's what most of the people say. Yeah. Meenakshi, any comment on that? Do you?
Sir, when you pinch and they move a bit, we take it as a surrogate for that. So that's what I do. But now I realize that I have to call sir and ask his opinion.
No.
I'll make a WhatsApp tell the call, sir.
No, these are the things which I had a difficulty in early part of my career, that how to, because we used to take it very seriously. Each and every point we used to take it very. Then I asked Werner Hacke in one of the international conference. He was busy munching his sandwich. He didn't give much importance to my question, telling you frankly. This question was too simple for him. But this is what he told me while munching his, I think, chicken sandwich or ham sandwich. He said, whatever you are not able, give the worst scores. Give the worst scores. And that is what Dinesh is also saying.
Supposing we pinch and the limb moves, maybe we can give a scoring to that. That's what we have been doing, sir. It never occurred to me that we should not do it that way.
Because you see, he will not, you can't test cerebellar signs in him. You can't test orientation in him. So, does he get... So probably that is that, give the worst scores to him and use our judgment, as you rightly said.
And I have a comment for Komal, if you permit me, sir.
Yeah, please.
If you want to thrombolize a patient who's got very odd things, do the most simple investigation. If you had done CT scan on this lady, 86-year-old lady, things would have been much easier.
Yes, sir.
MRI made things
actually, we have done the CT scan, sir. We have done this.
Don't do MRI scan. Do a CT scan, take a decision.
Okay.
Yeah.
Okay. And then after IV thrombolysis, you can do a CT angiogram, MRI angiogram, whatever you feel like. Your decision is made on CT scan.
Yes.
Once you do an investigation that glaringly shows you deficit, then your decision making becomes difficult.
This actually happened, sir. Actually, we have done a CT scan which was not showing much of the hypodensity.
Then go ahead and treat.
Yeah.
Based on CT scan.
Yeah.
And then after that, whatever you want to do.
But the deficit was so high, we were not very... Yes, but that increased our confusion. You're right, sir.
No, Dinesh, you are so true. This is a new learning now.
Yes.
Now we have this Carlos Molina. We have Carlos Molina from Spain. He had a series of lectures this year, including he had physically come to Bombay also in stroke meeting. And he said exactly the same thing, what you are saying. He said, when in doubt, previous slogan used to be, when in doubt, do the MRI. He says, when in doubt, do the CT scan. He said, don't worry about your GRE and microobliques and this thing. All our research has not been done on them. Our research is based on CT scan. When in doubt, do the CT scan. Follow the CT criteria and go ahead and thrombolize. And he said he does it all the time. So I completely agree with you.
Sir,
only one risk factor, sir, in this patient. High risk factor is relative of IAS. The rate is a risk factor.
Yes, sir, we have to show them the stroke. That is the thing. If I say the CT scan is normal and I want to go ahead with thrombolysis and it may bleed, It is like
you have to tell the relatives. We do a CT scan to look for bleed, not to look for stroke.
Not to thrombolize.
We look at stroke on the face of the patient.
Yes.
Not on the
So one more case I want to share, sir. Actually, the same thing we did. It was a 37 years male, sir. So he came in window period, dense deficit. Almost the NIHS was 25. We have done a CT scan. We have thrombolized the patient. And after thrombolysis, we have shifted him. We have done the thrombolysis in the CT room. And after that, we shifted for a MR. CT was absolutely normal. And we have shifted to the MRI, and diffusion showed similar large MC tertiary infarct. And there was a total MC occlusion. And then within 2 hours, the GCS further deteriorated and he had gross edema with midline shift. And in another 6 hours, the patient succumbed, sir. So after that little bad experience, we thought that we would see this MRI as well, sir.
You know how a batsman play a fast bowler?
Sir?
How a cricket batsman play a fast bowler? He misses a lot of balls. Some ball will strike your helmet. Some ball will strike your, gloves and pads. You forget it. The next ball is a new ball. Take it.
Yes.
I hit a 4 or a 6.
Right.
Don't remember bad memories. Remember good memories.
No, but that point is well taken, sir. We would do that, sir. That would save the time as well as help us.
That patient required endovascular.
Yes. Sir?
That patient required endovascular, your patient, no?
Yes.
Endovascular was the order of that patient, actually.
Actually, the infarct was quite high, sir. Even endovascular was not possible for him, sir.
So I think we had a great discussion. It is already 9:17. So can we wind it up now? Or anybody wants to make any comments? We had a great discussion, great moderation. Meenakshi or Dinesh?
Two messages from what we learned from you all, sir. One is that when in doubt, do CT. It's a great slogan, sir.
Yes.
When in doubt, I was advocating, when in doubt, do an MRI. Dr. Kabra sir and all that changed my perspective. When in doubt, do a CT, because you think what you do and make it, work to your way.
Absolutely correct.
Yes. Thank you, Devi sir. Thank you.
Very much, sir.
Thank you, Dinesh. Yes, Meenakshi, thank you, and Komal and Dr. Malaya. Nice to know you, Dr. Malaya.
Thank you, sir. Thank you so much, sir.
Thank you so much, sir. We have learned there are many new points, sir. Thank you so much.
So may I request Dr. Sanket wind up the meeting?
Thank you, sir. Thank you to hand over, sir. I believe today was a different meeting from the many meetings that we did so far, sir. The discussion opened up a Pandora's box in terms of guidance, in terms of understanding, in terms of making new decisions. I believe that's what makes this platform unique in terms of its outcomes. So I firstly thank our course director, sir, because without you, this meeting won't be possible. I want to thank our moderator, Dr. Meenakshi Sundaram, sir, for his excellent deliberation. I want to thank our guest speaker, Dr. Kabra, sir, for adding great new insights, new directions to our thinking. And each speaker, Dr. Komal, Dr. Malaya, gave us a different insight, a track in which we can take our discussions and learn something new from today's talk. So thank you, our speakers as well. We would meet again next month, with a new set of cases with the same, our best and our famous course director, the beloved Dr. Subhash Kaul sir and Dr. Sundaram sir. And hopefully, Dr. Kabra, you should join us again and to have this scientific feast. Yep. So with that, I would like to officially close and thank you each and everyone. Thank you to all listeners who are active today and listening to this episode of No Thrombosis. Thank you all. Thank you.
Thank you, sir. Thank you, sir.
Thank you, sir.